received this pamphlet. It is there with you. Please repeat this for me. Most of the people got it. Yeah, you repeat this, please. I realize that antimicrobial resistance is a public health priority. Please repeat. At a global and national level. And for medical professionals. As a dedicated practitioner of modern medicine. I commit to uphold the sanctity of my profession. By prescribing antimicrobials judiciously. With integrity and care. And with each prescription. I commit to assess thoroughly. Ensuring antimicrobials are used. Only when truly necessary. I commit to balance the benefit and risks. Considering patient health. As well as public safety. I commit to choose antimicrobial wisely. Guided by evidence. Stewardship practices. And the specific needs of my patient. I commit to defend against antimicrobial resistance. Preserving the power of antibiotics. For the further generations. Together, let us action contribute to health.
Let our actions contribute to the health
and happiness of all. Free from shadow of IMA. Thank you. Not only repeating, please try to follow it. Antimicrobial resistance. Thank you, Rabis.
Now, thank you, sir. Thank you, Krishna sir, for your enlightening lecture.
Now I request chairpersons to please felicitate the speakers.
A small announcement regarding the quiz. So, at the end of each session, you'll have a quiz, which is an online quiz. So, to participate in the quiz, you have to scan the QR code on the delegate tag. Once you scan the QR code, click on the quiz button. Questions will be displayed after each session for only 6 minutes. Click on the right answer and then submit your answers. Quiz winners will be awarded attractive prizes. So pick up your mobiles and scan the QR code on your delegate tags.
To preserve our ethnicity, we are felicitating our guests with Mangalagiri Pattu shawls. Regarding refreshments, tea and snacks are being served at the Centova stall outside the gym.
So, and also this is antibiotic awareness, AMR awareness week that we are having. So vaccines also will help in decreasing your AMR. It will decrease your infections, it will decrease your use of antibiotics, and will also help in your AMR. So thank you for this opportunity.
Thank you, sir. Thank you, sir, for completing before time.
So, see, every vaccine definitely can have side effects. The adverse effects can range from mild adverse effects to serious adverse effects. Mild adverse effects can happen in many of the patients. Just to say simple examples, so recently we had this drive of PCG vaccinations. Everyone were ready to take because they came to the home and gave it freely. Many of them had problems. They had abscess formation, they had lymph node swelling formation, but they were still ready to take the vaccine, even though they had the side effects. So it is not the side effects that is preventing one from taking the vaccine, is what I feel. It is the importance of the vaccine that has to be told to the people, that has to be given and incentives and then. And every vaccine, definitely, any drug or any vaccine will have side effects. Some we have to be aware of which are important, and many of them are only mild adverse events. Very rarely serious adverse events happen with vaccine because the clinical trials also for vaccines are completely separate. And there the safety is even more important than efficacy of this.
Sir, last question. Regarding COVID vaccine, what is your comment? People are having a lot of doubts. They are hearing in public. Can you kindly clarify? Particularly COVID vaccine. That's all.
So COVID vaccine, as I told, definitely, I think everyone will agree that COVID vaccine helped us in breaking the outbreak. That was its purpose. As in everything will have mild adverse events. Something, the important serious adverse event that we had with COVID, especially the Covishield or the AstraZeneca vaccine, is the BITT or the thrombosis, vaccine-induced idiopathic thrombosis. That was one very serious adverse event that happened in a minority of patients. Other than that, to say any viral illness is an inflammatory condition. So any inflammatory condition will lead to some thrombotic effects as well. So if it is induced to natural infection or if it is induced through vaccine. So by giving vaccine, we are preventing the adverse events due to natural infection. So that is what has to be taken forward rather than the side effects being highlighted for the vaccine. Of course, there are side effects. There will be side effects, but we prevented them from having the natural infection, which might have been more harmful.
Last question. You mentioned about BCG vaccination about the abscess certainly. It's certainly helpful about 10 cases. And we certainly granulation for extracellular absorption. In 2 cases, it was positive for jet cells and 8 cells. Then I have to start the ATT once again.
So it is a natural host response with granuloma formation.
Okay.
So we need not start it. Some patients who are
Thank you, sir, for enlightening us with most important aspect of halting dangerous infections beforehand, especially in adults, which is often missed by most of us. Now we shall proceed to our next topic, HIV Essentials, a vital guide for every practitioner. To present this, I would like to invite Dr. R. Harikrishna Garu onto the dais.
Good morning, Monica. I would like to invite Dr. Raywood Harikrishna Garu, MBBS, MD, Fellowship in Infectious Diseases, and is a leading consultant at internal medicine and infectious diseases. Ruji Healthcare, Guntur, Andhra Pradesh. His academic credentials are graduation and PG. He has graduation, undergraduation, and PG in the internal medicine in Manipal University, and fellowship in infectious diseases, University of South Wales, Australia. And his expertise in tropical medicine, treating HIV patients, infectious disease in critical care, infectious diseases in NCDs. And he had membership in lifetime member in CIDS, lifetime member International AIDS Society, member European Society of Clinical Microbiology and Infectious Diseases, AIDS Society of India, International Diabetes Federation. He is an active participant in various research activities and speaker in national and state conference. He is an eminent physician and inspiration to many of the budding doctors.
Good morning, one and all. Thank you, Dr. Vijay, and thank you to the chairpersons. Today's my talk is going to be on HIV, which is a essential topic where every practitioner, irrespective of the specialties, will come across at some point of time, or if they see a patient who is already on treatment comes to you for surgery or for some other modality, what shall we do? So I am going to talk very briefly and specialty specific rather than going deep into the theory part of the HIV. So my talk is going to be mostly on, is HIV still persistent in India? Is the prevalence rates are high or not? If we find HIV instantly as a pre-op checkup, or somebody who comes with a report which was done in the periphery comes to you for treatment, or people who are already on treatment, you want to change it or you want to know whether this treatment is appropriate or not. Or for our healthcare professionals, needle prick is very common. So what to do in those cases? And now we have guidelines for PEP, what we call it as pre-exposure PrEP. PrEP is pre-exposure prophylaxis, where one partner is negative, other partner is positive. So in those cases, how to go about? And for gynecologists, patient of HIV comes for conception and delivery, how to go about? So these are the areas which I am going to touch today. So many people ask us, is HIV, when we are discussing this topic to keep it in the sessions, is HIV still persistent in India? How many cases we are having in India? HIV is a disease which is spreading like under the blanket in India in a very, very large scale. So what are the statistics? So India is among the second largest country of HIV prevalence. So we cater large number of HIV active patients who are on treatment, or the number is continuously growing. So the statistics says 15 to 49 year group people, there is 0.20 number of patients among all the male patients. And people living with HIV in India is 24.67 lakhs, that is almost 2.5 million people living. And the annual infection rate is 66,000, and people death related to HIV alone is 39,000. So this is underrated number what we generally believe, because most of the HIV deaths may not be reported as it is because of HIV. They die with various causes, and we put the cause of death in those scenarios like cancer or cardiovascular events. But the preliminary disease that is causing these events is HIV. So HIV is still very prominent disease which we all need to understand, and which we need to see it in a bigger frame. What about us? Where are we in Andhra? Andhra stands second largest after Mumbai, after Maharashtra in HIV cases. We are seeing very fresh cases every year, every month we are seeing, we get references from various specialties of very young patients coming with HIV, young students coming with HIV. Prevalence rates are going high. We think that HIV is no more a disease of concern, but no, HIV is going high and high every year. So prevalence rates are 0.64%. 3,21,000 people officially on roll of treatment with HIV in Andhra Pradesh alone. And 5,200, around 6,000 patients are newly enrolling with HIV every year in Andhra Pradesh. This number may be high because most of the patients may not be enrolled into the national program. These numbers are only for those who are registered into the HIV practice or HIV care. So the numbers are very devastating with HIV. So it is time for all of us to understand what HIV is, how to control it, and how to prevent it. And HIV deaths in Andhra is around 7,000. So I can put it around 10 to 12,000 cases. So WHO has come up with a program called 95, 95, 95. What this 95 says? Among all the HIV positives, at least now we know 79% are aware of their HIV. So WHO says 95% should be this number. Among all the population who are suffering with HIV, 95% should know that they are HIV positive. That is the first 95. What is second 95? Out of those 95% who knows their HIV status should be enrolled into the program. So now we have 16.8 lakh people on treatment in India. What is the third 95? Third 95 is that those who are on treatment should be virologically suppressed of HIV. So once this is planned for 2025, and we are almost reaching to this number with the help of government, private organizations, NGOs in a very big scale. Other specialists may not be knowing how much of work is going on HIV, but there is a lot of research going on HIV, which my subsequent slides I will show you. So suppose a patient comes with to a general surgeon or to any specialty for a surgical workup or for fever workup, when the patient is confirmed with HIV. So he come and ask us what to do. So when any patient comes with HIV positive, so don't jump to the diagnosis or confirm that you are HIV positive and label him on his head that you are HIV positive. There is a lot of stigma still going on. So always confirm the HIV with either PCR or LSR. Our Western blot is the confirmatory test. It takes 24 hours to come. It is cheaper, 1,000 rupees one day. Even in Guntur, we are doing very regularly. So this confirms HIV. Then, if patient is affordable, go for PCR. And differentiation. We see a lot of prescriptions saying he is HIV positive. So there are two types of HIV which we need to differentiate HIV 1 and 2. The reason the prevalence rates changes, prognosis changes, treatment changes. So whenever we write HIV, please write HIV 1 or 2 for the sake of treatment. Just don't write RBD positive. Try to find out whether he is HIV 1 positive or HIV 2 positive. Once the HIV is confirmed, for all these patients, these are the baseline tests which we need to get it done before enrolling them into HIV treatment program. So basic tests will tell us is there any opportunistic infections or already established complications in these patients or not. Once we get the baseline test done, then as I told you, why do we need to differentiate HIV 1 and 2? Prevalence varies from 1 to 2. 2 is less common. 90% of patients suffer from HIV 1, 5% HIV 2. We see 3 to 5% with both HIV 1 and 2. Treatment varies in 3 different group of people. Transmission rate changes. When we see a HIV 1 patient, we counsel them differently. When we see HIV 2 patients, we counsel them in a different way. Progression will also change, and treatment also changes. So this is the graph. This is the tabular form where we can how to go about when we diagnose a patient with HIV. This is a brief thing which you can take a photograph. I can run through when patient is diagnosed with HIV. After ARP initiation modification, get a CD4 done, viral load, genotyping, or we call it as DST, drug sensitivity testing, just like cultures. We see whether this patient is sensitive or not to the group of drug which is very specific or what we are going to use. So this we generally do it patients who are already on treatment, not responding, virological failure or immunological failure. We want to change the residence, we generally do DSTs, and which is readily available in Guntur. And the criteria to get the DST is that viral load should be more than 5,000 and it takes around 1 week to come. So when you are planning to change the regimens, get a DST done, it costs around 10,000 rupees. And all the other viral screenings, LFTs, to check for the toxicity secondary to HIV or the drugs which you are going to change. And when we diagnose the patient, the first question he will ask is that what stage I am? How to tell the patient that which stage of the HIV he is on, and how to handle him and how to push him to the program very effectively. CD4, simple thing, CD4 count more than 500 is asymptomatic. Most of the times we don't pick this patient at stage 1 unless we are doing a screening or patient is going for blood donation or some other accidental findings or patient going for a pre-op workup, we find these patients. Stage 2, 350 to 449, this is the stage where we generally pick up the patients with unknown fever, the simple weight loss, loss of appetite. Stage 3 is where all of us will pick up the case. These patients most likely come with persistent diarrhea. Oral candidiasis is one very catchy thing to pick up the patients. Always ask the patient to show his tongue. So when you find oral candidiasis, until proved otherwise, we can go for HIV testing. And most of the patients will come positive if it is HIV positive in the early stages. And pulmonary tuberculosis is another entity. All of us will treat tuberculosis to some or other organ. Ophthalmologist will treat chronic uveitis, pulmonologist will treat lung, gynecologist will treat tubular tuberculosis. So any patient who comes with tuberculosis, before you start the treatment, try to get HIV testing done and find out whether it is HIV 1 or 2 before you start ATT. Then stage 4, this is the stage where we generally come up with patients with cancer and HIV encephalopathy. Patient is throwing seizure and CD4 is very low, less than 200. So once you find these staging, it is very easy to counsel the patient how to go about it in treatment modifications. So this is how generally HIV goes. Initially weeks to months, where what we call it as window period, where HIV may not be very prominently affecting the body. Then slowly it invades the CD4 cells for a period of months, years. Then it completely invades the CD4 and we see lesser CD4 count. When to start ART? Suppose patient we have diagnosed. Either you refer the patient or you may start treating the patient. After the session, you may start treating the patient with basic information also. So when to start patient? When to start ART? What are the guidelines says? Guidelines says test and treat. Any patient who is detected with HIV, start treatment irrespective of CD4 count, irrespective of viral load. So whenever we see a patient with HIV, earlier days the guidelines were saying you start it when it is 350, less than 400, our patient is symptomatic. Now the guideline says test and treat. As soon as the patient is fine HIV, confirm the HIV status with either Western blot or PCR, then go for treatment. So why do you, before going to start the treatment, why do you buy some time? We generally buy some time. We have a lot of experiences with young people coming with HIV incidentally found. So we don't start the treatment, we buy some time to counsel them. Counseling is very, very important. We have so bad pathologic experiences. The moment we say HIV positive, he will go out and commit suicide. And family comes back and asks us, this patient has come to your hospital, what happened, what have you told, and this patient committed suicide. We have many pathologic such stories with HIV patients who are diagnosed in a very young stage. So don't jump to the conclusion, break the bad news slowly. We buy time. Initially what we say it is positive, but we will reconfirm it, we will take time, come back with PCR report or Western blot. So he will slowly get convinced himself. 50% he will be convinced. So the Western blot comes. Then again we will counsel the patient saying that your Western blot is also positive, but don't worry, we will get the CD4 and see which stage you are in. Again, after 3 days we counsel the patient. Then patient comes with CD4 and viral load. Then we'll say your CD4 is 400, don't worry, your viral load is so less, so you don't need to worry. So breaking the bad news in HIV is very, very significant, and deaths we see so pathetic that many young girls, young students who comes with HIV positive, maybe through parents or through transmission in other sources, but please don't reveal the HIV status upfront in a deliberate way. So try to counsel the patient, which is very important. So why do we want to treat the patient? What is the necessity to treat the patient? When HIV CD4 is 500, viral load is low, why do we need to treat the patient? So the treatment should be focused on 4 points: clinical response, virological response, immunological response, therapeutic goals, and preventive goals. Clinical goals, we need to see that patient is clinically improved. Virological response, his viral load CD4 count should be more than 500. Immunological response, his viral load should be less than detectable. Therapeutic goals, are we treating with the right drug? Are we treating with the right dose? And patient is adherent to the treatment, no toxicities, and is he tolerating well with the treatment? Preventive goals, he should not contaminate to the society, he should not contaminate to the partner, he should not contaminate to his child. So these are the primary goals of treatment. So what to start? There are so many guidelines, and all the guidelines in 2024 said this is brief chart of various group of drugs. Now we have 4 active group of drugs which we are using for HIV, and all the national programs have come up with combination drugs with one single pill per day, which is more than sufficient. The combination pill which we are using now is called as DLT, dolutegravir, lamivudine, and tenofovir, which is available even in government and in private sector, which is easily available, very efficient and low cost. It costs around 2,500 to 3,000 rupees. So that can be considered as a first line drug. So first line drug, these are the recommendations for the different age groups and different populations, adult and adolescent, pregnant female, infant, children. So we have different guidelines for different patients. So stick to the guidelines, stick to the formulations. They are single drug single dose regimens. So they are very effective in the present era. So the newer guidelines says that you don't need to go for 3 drug regimens. We have 2 drug regimens now. We have long-acting drugs coming on the way. FDA have approved different combinations for 2 drug regimens. Now the world is moving towards long-actings. Whether you take psychiatry, whether you take dermatology, whether you take general medicine, whether you take diabetes, the world is moving towards long-acting drugs. So as with HIV. Even in HIV, we have long-acting drugs which are already approved. We can have capital with ethanavir, which is once in 2 months in an IM preparation which has been approved, and now in the pipeline in another 3-4 months there are another group of drugs which are already approved coming to India. One which I can discuss. This is the two drug combinations. Once we can take once in 2 months intramuscular form. This is already approved, which is being approved for TEP as well as maintenance therapy. Patient comes to HIV clinics, take the IM injection once in 2 months and goes off. This is the IM, how we use it. And this is the newer drug which has been newly launched in India, which we can use it once in 6 months intramuscular injection. This can be given along with already existing HIV medication, or we can slowly switch over the patient from the oral form to the intramuscular once in 6 months injection. Maybe by 2025 and India will have this molecule. You can tell most of our patients will come and ask, sir, do I need to take medication for lifetime? Do I need to take tablet for lifetime? I am having lot of toxicities. I have lot of stigma. Wherever I go, I have to take this medication like diabetes. So these are the things which are going to answer all the patients' compliances. So compliance is one of the biggest issue in HIV. So these kind of medications will change the HIV outlook. So toxicities. So opportunistic infections. If you see this graph, I can see this is all specialty driven. Tuberculosis, chest physicians will see. Oral candidiasis, dermatologists will see. Diarrhea, gastros will see. Herpes, again, dermatologists will see. Cryptococcal meningitis, neurologists. CMV retinitis, ophthalmologists. Bacterial pneumonia, respiratory. So HIV is one disease which affects entire medical branches. So every department will come across HIV in some or other form, and we need to be cautious that any of these patients come to us, please get a HIV test done. So HIV is not only the disease of general medicine or ID, HIV is disease of all the branches, which we should know the basics about it. So TB, all the specialties will be treating TB, and all the patients who are on TB, as I have told, need to be checked for HIV status. So patients who are already on HIV gets a tuberculosis, there are different guidelines. Patients whom we find tuberculosis and HIV both together simultaneously, we have to wait for at least 2 to 4 weeks before we start the HIV treatment to avoid IRIS. Or if the patient is critically ill, neurological symptoms or any other critically important symptoms, then take 1 week time, start ART and ATT simultaneously. Don't wait too much time. Vaccines, as Dr. Niren was talking about vaccine. Vaccine plays a crucial role in all our HIV patients. As a key population, HIV also comes into the key population, where we generally recommend our patients to go with as many vaccinations as possible. This will cut down the subsequent infection, cut down the hospitalizations and deaths. So vaccination plays a very crucial role. How to prevent? PrEP. Now we have a lot of guidelines where we can give the patient a monthly tablet where when one partner is negative, one partner is positive, we can go for PrEP. Andhra Pradesh is the first state to start PrEP with the association with government, a program called as PrEP. The post-exposure prophylaxis or needle prick, which everybody will come across. We get a lot of phone calls saying that I had a needle prick of HIV patient when I was operating, what to do. So 72 hours, start the treatment, get the test done. Even if it is negative, go for treatment. Check every 6 weeks, then 3 months and 6 months with ELISA or Western blot. Once it is negative, then you are considered as negative. Minimum treatment should be taken for 28 weeks. So this is for the gynecologist. U is equal to U. Now we have a session end of this complete sessions that U is equal to U, a short film which is going to be broadcasted end of the conference. So HIV positive mother can conceive, HIV positive father, HIV negative mother can conceive, the child can deliver a negative child. So when the viral load is zero, they can have an unprotected sex also, and they can conceive a negative child. Now we have reached a phase, it is almost getting eradicated. So comfortably gynecologists will go ahead if they find a partner HIV positive and one partner HIV negative, they can confidently tell that go for conception and childbirth. These are few modalities. So when to refer a patient? Any toxic situation, don't wait. HIV patients will react in a more aggressive way, deteriorate very faster. Don't wait till further more symptoms comes or if the patient develops any more complications. As soon as you see these symptoms, refer to ID. Thank you, I'm on time.
Thank you, sir. Thank you very much. Sir, 2 minutes. Can everybody stand up? This is the antibiotic awareness, antibiotic resistance.
SIMS, Nephrology Department. And next, I invite Dr. B. Paray Chaudhary, cardiologist at Guntur, and he received FSCC in 2014. Invite Dr. Murali, endocrinologist from Vijayawada, for this panel discussion. The topic for the discussion is, how do you treat me? I am an obese diabetic spilling all with residual wall motion abnormalities.
Very good morning, my teachers, seniors, friends, and colleagues. I thank Dr. Manujakshi Madam for kind introduction because she was known to me well when I was doing my nephrology graduation in Tirupati, and also thank Dr. Shivaram also. And I must thank the organizers for conducting this beautiful, fantastic conference because it is on par with any national conference. I must thank Dr. Harita and Nanda's team. And I am privileged to have Dr. Paray Chaudhary sir and also Dr. Murali, endocrine from practicing in Vijayawada, coming from London, to share this knowledge sharing session. Today we are going to discuss about a global health challenge which is in the continuation of how Dr. Shrikant has been elaborating us in the previous lecture. So we see a lot of this kind of patients, this multi-morbid, comorbid issue patient with diabetes, hypertension, obesity, with having mild albuminuria, and instantly detect a regional wall motion abnormalities. Because these kind of patients, they don't come to you, whether it's a medical expertise or surgical specialist, they don't come initially with cardiac event or a renal event. You will see these patients from maybe because of a small febrile illness to an advanced cancer also. But when you dig into the in-depth of this patient clinical history evaluation, you will find these abnormalities. But we tend to neglect it very easily because it doesn't matter to us most of the times. We have chosen this topic because across the world, about every year, 50 to 60 million people are dying because of cardiovascular renal events contributed by heart and kidney related deaths only. And probably all tertiary care hospitals across the world are flourishing because of outpatient or inpatient hospital admissions because of this diabetes, hypertension, cardiovascular or kidney related hospitalizations only. And obviously, a single admissions of these patients we will make them bankruptcy because of huge healthcare expenditure. And a lot of things have been happening for the past 10 years to understand the science and biology of this entire disease spectrum. And not only that, many doctors are also not spared because of these cardiovascular renal events. In the the recently article coming in the English newspaper, in a government hospital, when they evaluated about 500 doctors, 53% were found to have diabetes and 24% were found to be hypertensive. So obviously, they tend to develop cardiovascular renal manifestations in their lifetime. So it's not a didactic lecture. We wanted to make this an interactive knowledge sharing session with the help of endocrine and cardiologists. So this is a thematic case example that we see routinely in our practice. Maybe primary physician to an oncologist or a cardiologist or a physician. So we have here a middle-aged diabetic obese marketing guy, Mr. Kumar, with 40 years of age, and he is having BMI of about 32. He visited a physician and with history of 5 years of diabetes and 2 years of hypertension. Physician is intelligent guy enough to see that with 5 years history of diabetes, he has been put on insulin and oral drugs, indicating that his beta cells are lost, maybe the patient having higher insulin resistance, and he wants to do a comprehensive health assessment without any symptoms. On health assessment, he was found to have his creatinine of about 1.7 milligrams and GFR about 50 ml per minute. And his urinary albuminuria is about 1.5 grams per gram of creatinine. And when he found to be having ECG, having about QS complexes in inferior leads, and then the RWMA, regional bar abnormalities, were found in the inferior aspect of cardiac muscle, along with dyslipidemia and diabetic retinopathy. So the diagnosis is diabetic kidney disease with stage 3A, A3, coronary artery disease, diabetes mellitus, hypertension, obesity, and dyslipidemia. Generally, when we see these kind of patients, the objective of treatment is to give a lead and lead a life equal to any other healthy person, reverse and prevent kidney failure, avoid an adverse cardiac event with a healthy metabolism. So we have a middle-aged diabetic patient with CKD stage 3. So first thing when you see a patient like this is understand the disease and stage this patient at what stage of CKD patient has. Everybody, we routinely evaluate every patient whether he comes with a fever or an advanced cancer. We routinely perform urine analysis and blood investigations. With these two markers, you can diagnose CKD. One is blood marker with serum creatinine estimation and measuring eGFR out of CKD APA 2021 formula and estimating urinary albumin creatinine ratio. Very easy, and it doesn't cost us much also. But what we miss is estimating eGFR will not be done 99% of times to a patient, which is probably one of the reasons why we neglect underlying silent CKD in a patient. CKD in a multimorbid patient is not a simple bystander, it is a disease multiplier. So this patient has CKD stage G3A and proteinuria of more than 300 milligrams. What happens when we do not see and act now? So generally, in 2000 because last 10 years, because of widespread adoption of electronic health records and EMRs, quality data has been captured in across the hospitals in Europe and in America. Though we have patient volumes, we could not access the patient's data, but we still utilize some of the risk prediction models. Previously, when you see a patient like this, we just wait and watch whether the patient going into kidney failure or adverse cardiac event like that. But because of availability of risk prediction models, this patient will have about 40% risk of progression to kidney failure in the next 5 years, and even 10-year risk of cardiovascular risk is about 30% by ASCVD and TWIS3 trials. When you look at the creatinine value and estimate the GFR, I wanted to stress upon a small discussion about GFR also. Generally, our GFR is about 100 ml per minute. As we age, especially at the age of 30 years, we lose 1 ml GFR every year. That means when your baseline GFR is about 100 ml at 30 years, by the time you reach 70 years, you lose about 40 ml of GFR. You have about 60 ml GFR at the age of 70 years. That's the reason why patients who are having people after the age of 70, the incidence of CKD prevalence is about more than 25 to 30%. What happens when the same patient at the age of 35 develops diabetes and obesity? Instead of losing 1 ml GFR every year, they lose 7 to 10 ml of GFR. So this patient having 50 ml GFR at 40 years, if he loses 10 ml GFR every year, obviously he lands up in dialysis next 3 to 4 years. So this is the common scenario we have been following since up to 2016 on. So I have been in practice seeing thousands of patients since 2003. What we had done so far until 2016 and 17 is we used to prognosticate the patient that you will have to land up in dialysis in the next 3 to 4 years, and he will be on a mission to find out a kidney donor to undergo kidney transplant where there is a part of life. So they have to wait and watch for dialysis and kidney transplant, or at some point of time they will die because of sudden cardiac event at point, many a times. So this is what's happening before 2016. But because of breakthrough understanding of the science, better availability of drug molecules, and integrated technology into our healthcare, lot of things have been changed for the past 10 years. We are entering into the era of personalized predictive proactive care, where you can monitor minute-to-minute glucose readings through a Abbott freestyle replay or a blood pressure monitoring for risk factor control. Even your Apple Watch can track all your health metrics by 24/7 and it enters into your doctor's inbox. And with the availability of newer drugs like Forxiga, dapagliflozin, Kerendia with finrenone and semaglutide, there is a whole spectrum of changes happened for the past 10 years. So where you could be able to avoid lifetime dialysis requirement when you pick up the patient with early stage CKD. So the main question here is identification of the patient early stage. So I request all the physicians, surgeons, wherever, because 90% of these patients do not come to a cardiologist or a nephrologist. They will be in the hands of a physician or surgeons. So you need to understand basic understanding of the comorbid illnesses of the disease spectrum and the better understanding of CKD and cardiovascular issues. So this is the holistic approach. I wanted to end this because I would like to, because there are 3 drugs will be there which helps in reducing the cardiac and renal events. So I would like to ask Dr. Perai Chaudhary to manage how you manage this cardiac assessment patient for this patient.
Thank you, Ramakrishna. I would like to thank the organizer for giving me this opportunity. This is a patient, young male, who is obese and has multiple risk factors with CKD and alburia. He had asymptomatic CKD as evidenced by QS in inferior leads and RWMI in RPD echogram. So how to approach this patient? Shall we go directly to angiogram, because coronary angiogram has its own risk in this patient. So as the patient is asymptomatic, I would like to test his metabolic ischemia, myocardial ischemia by non-invasive test. Like the simplest is exercise electrogram, that is by TMT. Other things are by stress echocardiogram, nuclear stress test by SPECT imaging and PET imaging, and the CT coronary calcium score. Mainly it is useful for risks, diagnosis, and of course, and finally the invasive coronary angiogram. So first I would like to so this patient, we have to establish the CAD by diagnosis of by non-invasive test. This patient is asymptomatic, so I would like to induce myocardial ischemia by non-invasive test, like is by TMT, stress echocardiogram, and the nuclear test. If the patient is positive for by this test, we can go for invasive angiogram and revascularization if, in the same setting. If asymptomatic is negative, then we can proceed with careful guideline directed medical treatment and close follow-up. So, but what are the reasons for asymptomatic CAD in this patient? Probably one is recalibration, small vessel occlusion, or well-developed collaterals, and infarcted myocardium with no viability. These are the reasons why patient may have symptomatic CAD. So, if the non-invasive test they suggest to high risk features, then we have to straight away go for the coronary angiogram and revascularization. If the